Good afternoon. Thank you for joining us for the the Sexuality Education for Pediatric Providers webinar by the Illinois Chapter American Academy of Pediatrics. So, this is the third webinar of a five-part webinar series on adolescent health topics, and the following webinars are the first two have been recorded and the slides are available on the website. And then for this presentation, following the presentation, we will be posting the slides and also the link to the recording. The webinar planning group includes Dr. Parvinian, Dr. Kasky, who is also the presenter, Ms. Sanabria, and then Olivia Phillips, myself.
Hi, everybody. This is Kathy.
We also have the CME application reviewers, Dr. Judy, Dr. Leischner, and then for content reviewers, we have Dr. Judy and Dr. Cannell. For commercial disclosures, myself and Dr. Kasky do not have any financial disclosures. And also, funding for this webinar is provided in part by the Illinois Department of Public Health through funding from the Adolescent Health Program. For the CME accreditation statement, this webinar is credited for one AMA PRA Category 1 credit for physicians, and credit should only be claimed commensurate with the extent of the participation in the activity. And it is also approved for one continuing education credit for the following licensed professionals, and also just to note that qualified intellectual disabilities professionals may apply the same hours as well. This webinar is also being recorded, and again, it will be made available immediately following the webinar at our website, illinoisaap.org, and it is eligible for CME CE credit. It will be eligible for CME CE credit once we post it on our learning platform around May 2019. If you have additional questions, please feel free to contact myself at ophillips@illinoisaap.com, or as well as my phone number, 312-733-1026, extension 209. During this webinar, participants will be muted, and so please type your questions in the chat box below, and they will be answered at the conclusion of this presentation. We do encourage that there is a discussion, so then that way someone else more than likely has the same question, so we're asking if you can go ahead and type those in there. And again, at the conclusion of this webinar, attendees will be emailed a link to complete an online evaluation. Once the evaluations are submitted, I'll go ahead and send a certificate of participation for your CME or CE records, and this will likely occur the week of April 1st. The resources for this presentation are from Future of Sex Education, American Sexual Health Association, Advocates for Youth, and also the American Academy of Pediatrics. And so before we begin, I'd just like to introduce our speaker, Dr. Rachel Kasky. She's an associate professor at the University of Illinois Chicago College of Medicine and School of Public Health. And she's also chief of the Division of Academic General Internal Medicine and Geriatrics at UIC. She's board certified in both pediatrics and internal medicine and is a primary care provider for all ages. She's also a champion for transitioning youth to adult health care. And thank you, so I'll turn it over to Dr. Kasky.
Thank you, Olivia. And it's a pleasure to be here today. I am just going to get the slides up and running. Hopefully, there we go. Okay. All right. So, truthfully, hold on one second. There we go. Hopefully, Olivia, are the slides projecting properly for you?
Yes, they are.
Okay. All right. Sorry for that. Just wanted to make sure those were moving because they weren't moving properly on my end, but I think we're working now. So just to start, obviously, human sexual development, sexuality is a very important part of adolescent growth and development. And it's a very broad topic. And I think I want to just start by acknowledging that this is also a sensitive topic for many people and perhaps some of you on the phone. And how we approach this varies a lot by our individual practice and beliefs and so forth. This discussion today is really meant to be a broad overview to really encourage discussions around sexuality and sexual health with adolescents. And we are happy to discuss questions, thoughts, concerns at the end. And hopefully this is something that you can use in your practice, and for some people as well in their personal lives as they work with adolescents that may be their own children or family members, friends, and so forth. So certainly the AAP values healthy sexual development. This slide is an example of a sample of publications from the AAP on healthy sexual development during childhood and adolescent years. There's certain things you could read about here in more detail if you'd like. The learning objectives for our talk are to identify effective sexual health education tools and resources for patients and families, interpret patient situations in which further sexuality counseling is necessary, and provide education to aid in planning safe, professional, and compassionate treatment options to patients with regard to sex and sexuality-based behaviors. So let's talk about sexual education. Research has shown that while organizations like the American Medical Association, the American Academy of Pediatrics recommend that adolescent primary care visits include time to discuss sexuality and receive counseling on sexual behavior, the American College of Obstetrics and Gynecologists advise that contraceptive counseling be included with every visit for adolescents and young adults, including those who are not yet sexually active. But the data suggests that only 45% of young people aged 15 to 17 years report that they spent time alone with their doctor or other healthcare provider during their most recent visit. Many healthcare providers do not talk with adolescent patients about sexual health issues during primary care visits. And when these conversations do occur, they are usually very brief. In one study, conversations with patients aged 12 to 17 lasted an average of 36 seconds, so less than a minute to discuss sexual health or contraception. Many adolescents feel uncomfortable talking with their healthcare providers about sexual health issues, and many providers also have concerns about discussing these issues. So this is important because if patients are uncomfortable and providers are uncomfortable, these discussions are unlikely to occur and they're unlikely to be very effective. Concerns about confidentiality certainly can limit access to sexual and reproductive health, especially when young people rely on their parents' health insurance. So in 2013 to 15, 18% of all adolescents 15 to 17 years of age and 12% of young adults 18 to 19 years of age were covered by their parents' insurance. And those that were covered by their parents' insurance reported that they would not seek sexual or reproductive health care because of concerns that their parents may find out. Among females 15 to 17 who report ever having had sex, those who reported concerns about confidentiality were 1/3 as likely to have received contraceptive services compared to those who did not express similar concerns about confidentiality. So this is certainly important, and it makes sense. Adolescents often don't want to talk with their parents about issues related to their sexuality or interest in contraception, and that includes those who are not yet sexually active. Many are not yet ready or interested in having that conversation with their parents. So we will discuss what sexual education is and how providers and healthcare professionals can use practical and accessible resources to provide comprehensive sexual health education to patients and family members. So what is sexual education? Sexual education is the way people gain information, skills, and motivation to make healthy decisions about their own sexuality. It consists of high-quality teaching and learning about a broad variety of topics, exploring personal values and beliefs related to sex and sexuality. It can take place in schools, community settings, physicians' offices, or certainly at home as well. As development occurs, youth are faced with important decisions about relationships, sexuality, and sexual behavior. The decisions they make can have an impact on their health for the rest of their lives. It is important that they are provided age-appropriate, comprehensive knowledge and understanding of sex and sexuality to make healthy decisions. Discussions about abstinence, contraception, unintended pregnancy, and sexually transmitted diseases will help young people develop the skills to take responsibility for their health and well-being. Additionally, depending on the age of the adolescent, their ability to make healthy decisions about sexual activity may be limited. And for those of you who were with us on our last webinar about the teen brain development, it's very important to consider each adolescent's individual capacity for really making thoughtful decisions and understanding consequences of their behavior. Sexual education is effective for patients and families. Research shows pediatric providers who openly and routinely discuss sex, sexuality, and overall sexual health during routine visits are able to initiate effective and informative conversations with patients and caregivers, while also creating a comfortable space for future conversations. And I think what this just shows is it normalizes this conversation. If this is something that we frequently bring up and discuss during visits, adolescents over time will not only expect the conversation, but will likely become more comfortable with that conversation. Beginning in the 1970s, due to concerns over teen pregnancy at the time, the U.S. developed widespread support for sex education in schools. This is important as it can vary depending on the state and population served by the school districts. For example, currently 24 states and the District of Columbia mandate sex education in school. Of these, 22 states and the District of Columbia mandate both sex education and HIV education. 2 states mandate only sex education. Now, even though there are differences in what's mandated by state, how this actually plays out within schools and school districts can vary greatly, and we certainly see this here in Illinois. In contrast, 34 states and the District of Columbia mandate sex education and HIV education. Of these, 12 mandate only HIV, meaning HIV can be discussed without a discussion of sex or sexual activity, which I think sounds crazy, but technically that is what could happen. Across the country, we are seeing more broad, comprehensive sex education rolled out to schools, but this can vary a lot by school district and geographic location in terms of how progressive and or conservative different districts may be. Here in Illinois, we have not just sex education mandated, but require sex education with the mandating of HIV education as well. So both have to be covered. When providing education in Illinois schools, it is required to be, quote, medically accurate, which is interesting that even has to be stated. It has to be age and culturally appropriate, which makes sense, and should be unbiased. Further, in our state, the following content are required of educational institutions. It has to cover contraception, abstinence should be stressed, importance of sex only in the realm of marriage is recommended, negative outcomes of teen sex, avoiding coercion, and in terms of inclusion of HIV education, condom use and abstinence is to be stressed. Each of the topics are stressed to children if their parents or guardians opt into participation in sex and HIV education in schools. In Illinois, parents and guardians do have the option to opt children in or out of programming. So keeping these areas in mind when providing care and education is important, as that can aid in how you approach these topics to patients. I will say here in Illinois, different schools practice different models of opting in and opting out. For many schools now, it's an opt-out process, meaning you have to actively remove your child from that education, not opt in, which makes more sense. So for if you don't want your child to participate in sex education, you have to sign a form asking them not to. Otherwise, all children will receive the education. What children receive can vary greatly, but it's also a great starting point for conversation in the office by asking what has been covered in school. What did you learn about this? What's been talked about? In many Illinois schools, particularly in the Chicago and Chicagoland area, this education starts in either 4th or 5th grade and continues into high school. So sex and sexuality education. Abstinence-only or abstinence-centered education provides knowledge on delaying sexual activity until marriage. Research has shown that abstinence as the primary prevention method to avoid sexually transmitted infections and unintended pregnancy, of course, as it is you could argue, the most sure-proof way to avoid both. However, we know that abstinence-only education has been shown multiple times to be less effective in resulting in healthy decisions regarding sexual behaviors. With abstinence-only or abstinence-centered education, topics such as puberty, reproductive anatomy, and sexual health are often not covered in depth. This approach to education has proven ineffective in decreasing sexual activity among youth and teens. So by educating teens about abstinence does not make it more likely that they will abstain from sex. Additionally, research suggests that promoting abstinence only outside of marriage while withholding information on contraceptives does not stop nor delay sexual activity. Rather, they have been found to place youth and teens at increased risk of unintended pregnancy and sexually transmitted infections as they have not received adequate or comprehensive education on those topics. Very few schools do exclusively abstinence-only education at this point, though I'm sure there are some out there that do. Most schools incorporate abstinence education as part of a comprehensive sexual education program. Comprehensive sexual education utilizes a holistic approach to providing youth with tools and resources to make responsible and healthy decisions. It provides age-appropriate, accurate, and complete information to youth to help reduce risks of sexually transmitted infection and unintended pregnancy. Comprehensive sexual education is the best option when educating patients about sexuality, as it's inclusive. It provides equal information on all areas of sex, sexuality, growth, development during adolescence and into adulthood, and provides youth with much more robust understanding. As a pediatric provider, engaging with patients and their families about their sexual health can be challenging, and it can be a very sensitive topic. However, it can be helpful to approach the topic through the use of 3 learning domains. First, the cognitive domain refers to information being shared by the provider and acquired by the child or adolescent. Next, affective focuses on feelings, values, and attitudes that are beginning to develop in our adolescent patients. And lastly, behavioral touches on communication, decision-making, and other skills that align with behaviors of a child or adolescent. Each learning domain is essential because sex and sexuality is a multidimensional construct and requires addressing a variety of areas to ensure a safe and positive way of sexual health development as youth mature. Much of the research has shown that while comprehensive sex education is beneficial, there's no, quote, one-size-fits-all method, if you will. It really varies by age, socioeconomic groups, race, ethnicity, geographic areas. However, a component that the American College of Obstetricians and Gynecologists point out that community-centered efforts have been a key component of effective programming in the past. So pediatric providers working across sectors could be very effective to address sex and sexuality among patients. So for example, a study conducted by the CDC on birth rates among teens aged 15 to 19 saw a reduction of birth rate among those at-risk youth due to prevention and intervention collaborative programs that spanned providers, schools, religious organizations, community centers, and so forth. Involving the community, children and adolescents, along with their parents and caregivers, may be more receptive to discussing sexual health, or at least it ensures another opportunity for discussing sexual health. As we know, not all youth will necessarily receive this education in each of these sectors, so the more broadly available this is, the more likely youth are to receive the education and training. Many adolescents with special health care needs are sometimes considered asexual or can be excluded from receiving sexual health education. Pediatric providers are encouraged to provide education that is appropriate and still similar to their peers without disabilities, so really treating them the same. Being inclusive and appropriate of anatomy, development, sexuality, contraception, and STI prevention, depending on their care needs, should not just be on par with their peers, but should also be included at other places where they receive education, such as schools and community partners. So meaning we want to be inclusive of all youth at any place that they may receive education. And so that includes the school-based programs, community-based programs, as well as how we talk about this in our own practice. Speaking with parents, caregivers, and other community partners who work with special populations is one aspect of care coordination that can be beneficial to ensuring that children with special health care needs receive care and information necessary for healthy sexual development. Discussing sexual orientation and identity is critical. Comprehensive sex education should not marginalize lesbian, gay, bisexual, transgender, non-binary, or youth who are questioning their sexuality as they develop. When providing education on sexual health, providers can use language, tools, and resources that emphasize gender equality and empowerment. This will not just engage patients and caregivers, but also create a safe and comfortable space where youth can discuss their sexuality in regards to their gender identity. And this is particularly important as adolescents are often just trying to figure this out, and we are focusing on time points in which many are questioning or unsure, and having the opportunity to talk about this in a safe space is very critical, not only for their own confidence, but also in anticipating risks for their own sexual development and so forth. So let's talk a little bit about tools and resources that are available for providers to use. So Bright Futures tools and the Bright Futures guidelines are both resources for adolescent care. Bright Futures tools and resource kits includes forms and materials that can relate to preventive health supervision and health screening for all ages, including adolescents. These can certainly be adapted to meet your practice needs or your specific population. The social behavioral questionnaires cover sexual health, as well as other important topics such as nutrition, relationships, school, and they all take a gender-neutral approach, which is very important. So we will take a deeper dive into the Bright Futures topic at our next webinar on April 22nd if you're interested. So creating a welcoming space. Speaking with patients about sex, gender, and sexual orientation and their specific experiences is sensitive and can sometimes be uncomfortable for patients and their families and perhaps some providers. It is important to work to create a safe and comfortable space that's welcoming and encourages patients to speak with you about this topic. So there's a few things to think about when creating a safe space. So education and training is important. In order to create a safe and comfortable environment, being educated on what creates a welcoming environment is important. So assess the needs of your practice or facility and seek out training and education that corresponds with those needs. This could come from different speakers coming to educate your practice, different curriculums that are available online, and going beyond the traditional education. And for some practices I've talked to, this is as simple as just taking a walk through your space and making sure that it not only is appropriate for young children, but also appropriate for adolescents and teenagers. And that can be as simple as the type of material you have hanging on the wall, what's playing on the TV screen, how we talk to our patients, and so forth. So sometimes it's as simple as the aesthetics of our practice that make teenagers feel more comfortable. Understanding barriers and risks. There are various health and non-health risks and barriers that those who identify as LGBTQ encounter. For example, increased substance use, mental health issues, sexual and reproductive health concerns, and partner violence, in addition to stigma, discrimination, and more. So as healthcare providers, being aware of these barriers and risks, in fact, aids in providing the best patient care we can. We need to be sensitive, compassionate, and show empathy through using proper terms, and that may be using proper pronouns for some of our youth if they are questioning their gender orientation. directing patients to proper resources, and understanding that seeking out care can be difficult, and will encourage your patient to continue to seek out care options and feel comfortable in doing so. Integrating strategies to ensure you are creating a welcoming environment include assessing your current environment and seeing where changes can be made, as we discussed. Another strategy is reviewing and keeping up to date with policies that may impact specific communities and populations and incorporating those within your practice. And sometimes those policies are ways to change your electronic medical record, to have flexibility in gender pronouns, or ensuring that when taking sexual health, we always ask if someone is sexually attracted and or sexually active with males, females, or both, instead of just assuming that our patients would be in heterosexual relationships. And community support strategies. So collect and assess feedback from families, patients, and the community. Possibly open the clinic to host a focus group or education for teens that could be conducted by a community organization. Have an established contact who can assist patients with feedback, comments, or resources. Consider current community partnerships and outreach to see how they can work together to continue to provide care in a welcoming space. And at some practices I know of that have a fair number of youth that identify as being LGBT or Q have partnered with different community organizations that provide social support for adolescents going through this adolescent development. And that can be great to just have those resources available at clinic. So confidentiality. We touched on this earlier. Confidentiality is really critical when talking about sexual health. It's important when talking about many facets of healthcare for youth, but it's particularly critical for sexual health and sexuality. Some adolescents feel discouraged from seeking medical care or counseling for sensitive topics like sex, and they may have concerns about confidentiality when visiting a provider. So during routine visits, confidentiality should be discussed with both patients and their families. Laws do differ by state. Pediatric providers may make themselves or should make themselves aware of their state's consent laws regarding teens and adolescents seeking care without their parents' consent. Research has found that teens who have the option to privately and confidentially speak with a pediatric provider are more likely to be open to discussing concerns about reproductive health issues at school, mental health, and so forth. So being knowledgeable about state laws can assist you in how you discuss confidentiality with both teens and families. Some find this to be a tricky subject to bring up, but what I found is most helpful is being very consistent and repetitive. So I always explain to adolescents with their parents in the room, I usually start around age 11 or 12, I explain how confidentiality works in our practice. And I explain it the same way to everyone. It feels very normalized. It feels like this is just another routine policy, procedure, what have you. And we walk through very briefly in about 30 seconds what confidentiality means, what topics are covered under confidentiality for adolescents, and importantly, when confidentiality may need to be broken. And those are rare occurrences, usually only when when I feel a youth may be at great risk of harm to themselves or others. But it's important to just bring up the fact that there are times confidentiality could be broken. Another consideration is commercial insurance coverage for health insurance. So as anyone who has commercial insurance on the phone knows, the person, the primary holder of the insurance will frequently receive a billing statement or explanation of benefits, EOB, and those are now sent very quickly after usually receipt of any care or procedure. So it is possible that if an adolescent is getting care without their parent or caregiver's knowledge, that parent could receive an EOB or explanation of benefits. The detail that is in those forms varies greatly. For some insurance companies, it simply just states that there was a visit and professional visit done, and that's about it, the date and so forth. For others, it has more detail on if there was labs ordered, any medications given during the visit, and those sorts of things. So it is that is an area that can be gray, and Often we don't know until the EOB is received how much detail is going to be on that. For some adolescent patients of mine who are covered under their parents' insurance, they have opted to not receive specific care just around contraception for fear their parent could find out, and in which case I refer them to places they could get that out of pocket, such as Planned Parenthood. So in this next section, we'll discuss a fundamental area that pediatric providers should be knowledgeable in when providing sexual health and counseling. You are about to visit your next patient, and their chart shows the following: gender, trans, FTM, or female to male, orientation, gay, pronouns, they, them, parity, G1, P1. So prior to meeting the patient, there may be some confusion, particularly if this is something you're not familiar with. Sex, gender identity, and gender orientation, preferred pronouns, and other similar topics can be a challenge to keep up with, specifically with patients who are still working to identify these factors themselves. So when it comes to language around sex and gender, it is important to break down differences, right, and understand these different constructs. And this will also ensure you're less likely to offend adolescents as they're thinking about this. So let's talk a little bit about terms and definitions that are important when providing care to patients. So sex. Sex is defined as organs, hormones, genitalia assigned at birth. The terms associated with sex are traditionally male, female, or intersexed, meaning that there's a variation of both male and female characteristics due to an underlying medical disorder. Gender is how a person identifies and can differ from their presumed sex. So if we think about it, sex is a biologic construct and gender is a social construct. For example, sex can be seen as the hardware of the body and gender as perhaps the software. It is how someone views themselves, and therefore terms associated with gender can vary from terms associated with biologic sex. Some terms associated with gender are cisgender, which is a common term these days, meaning the person's sex matches their identity. I would call myself cisgendered. I was born female. I identify as being a female. I use female pronouns. Transgender refers to when sex does not match gender and can be those who have transitioned female to male, often abbreviated FTM, female to male, or male to female, MTF. Additionally, genderqueer or gender fluid refers to a person who does not identify specifically as male or female and is more fluid between the two. As a provider, when thinking about gender, it can be viewed as a spectrum where perhaps females at one side, males at the other. Genderqueer or gender fluid is sort of in that middle, and where on the spectrum can vary greatly by person. Those who identify as genderqueer or gender fluid typically use pronouns they, them, instead of he or she. Sexual orientation differs from both sex and gender. And this is really important. And this is where I see a lot of people make mistakes. Being transgendered is very different than being gay. So sexual orientation describes a person's attraction, whether to the same or opposite sex or gender. So terms associated with this, of course, include straight or heterosexual, homosexual, bisexual, gay, lesbian, pansexual, and pansexual meaning attraction that occurs without taking into account sex or gender. And then some may consider themselves asexual and are simply not attracted to others. So we cannot presume that a patient who is transgendered is gay or straight. Those are separate conversations and separate questions that need to be asked. So as with sex, gender, orientation, pronouns come into play all the time, and we've already referred to some of these. It can varies if someone does not identify as a specific sex, gender, or orientation, and so whether an individual uses he, his, she, hers, they, their, them, is really, you won't know unless you ask. And what's been striking to me about this is, I think as a culture, of course, this is becoming more and more common, but I now have many colleagues, students, residents who include their pronouns on all of their communication, including their signature on their email. So I think this is something we're all becoming more and more familiar with. And in many ways, you could consider having this part of an intake form, just as you might ask about medications and other things. You could consider asking preferred pronouns just so that it's documented. The American Academy of Pediatrics released a statement regarding homosexuality among adolescents in 2004. Since then, the Academy recognizes the importance of keeping up to date with changes regarding sex and sexuality and how that can help inform healthcare professionals how we provide care for youth who identify as LGBT. Some of the leading takeaways from this policy are: if a pediatrician does not feel competent to provide specialized care for sexual minority teenagers and their families, he or she has the responsibility to evaluate families and refer for medically appropriate care. And I think this is important because if you as an individual or if your practice has barriers or personal barriers and or physical barriers that you feel do not allow you to provide good care for sexual minority youth, it's very appropriate to refer to another practice or another provider. Pediatricians who do provide care to sexual minority youth should follow the same prevention screening guidelines as outlined in Bright Futures or that you would use for any adolescent. LGBTQ adolescents, including men who have sex with men and women who have sex with women, should have sexual behaviors and risks assessed just as any youth would, and should be provided STI and HIV testing according to recommendations for all patients. Contraception, including emergency contraception, should be offered to women regardless of their sexual orientation, as well as discussions of barrier contraception. So it's recommended to talk about condoms and dental dams with women regardless of their sexual orientation, as many adolescent women who are identifying as being lesbian may have had male partners or may have male partners in the future. So it's important, again, to just be fully comprehensive and provide education on all aspects of prevention. Strengths, resources, and risks should be assessed, and targeted behavioral interventions should be implemented to allow adolescents to maximize strengths and acknowledge and minimize risky behaviors. Pediatricians should be available to answer questions, correct misinformation, and provide the context that identifying as being lesbian, gay, bisexual, transgendered, or questioning is normal and it is okay. And it also can be very fluid during this time in life. Transgender adolescents need to be supported and affirmed in particular. They need education and often referral for the process of transitioning, and whether that is to a clinic that focuses on that. Sometimes certain endocrinologists in some practices focus on transgendered youth or youth considering transitioning. And so referral process is often needed for these adolescents. We need to support parents in working through these issues. Some parents are more open and some are less open when discovering their child may identify as being anything but heterosexual. And I think that's very important to support parents through this as well. Provide parents resources to read, or there are even support programs out for parents of sexual minority youth and or parents of youth who are transitioning their gender. We need to support and create gay, straight alliances at schools, support the development and enforcement of zero tolerance policies, including teasing, bullying, harassment, and so forth. Many school districts have been proactive about bullying policies, particularly around sexual orientation, but this is certainly something we need to support as a profession. So educating ourselves about organizations that serve sexual minority youth and or their families in our community can be helpful, as well as there's now a lot of information online for these families. If you're interested, the Gender Unicorn is a free resource that provides education on sex and sexuality. It gives a comprehensive visual overview of the differences between identity, attraction, sex, and expression. It has been updated through the years to continue to incorporate differences among individuals and ensure that everyone's experiences are taken into account. The newest version provides a separation of romance and sexual attraction. and understanding that labeling continues to change, which is true, this is a fluid process, and reinforces that current understandings have changed and will continue to change and expand throughout time. This resource may be beneficial to share during staff meetings with patients, families. The visual is generally found to be fairly inviting and informative and very age appropriate, so it can be used by young adolescents as well as older adolescents and family members. So adolescents and teens with special health care needs. We spoke briefly about this group. The Office of Adolescent Health states that since there's not a single definition, the estimates regarding the number of youth with disabilities residing in the U.S. has been evolving. There's different data out there. The National Survey of Children with Special Health Care Needs identified that about 1 in 5 teens have a special health care need. The American Community Survey estimates that more than 1.3 million U.S. youth have a disability. And additionally, among children 0 to 17, adolescents have the highest prevalence of special health care needs, which reflects conditions that develop or are diagnosed later in childhood. So regardless of the exact number, the take-home is that there are many youth born with or who develop over time a special health care need. However, this should not hinder the way we approach sex and sex education to these youth. The AAP have updated previous sexual education clinical reports in 2016 regarding sexuality education for children and adolescents. In this report, the AAP emphasizes that children and adolescents with any disability should still receive accurate, precise information regarding sexual health. The report mentions that further counseling, referrals, and sharing of resources can be helpful as well. Young people with disabilities need accurate information and skills and have the same rights as individuals without disabilities. So there are 5 things providers should keep in mind when addressing sex and sexuality with youth with disabilities. The first is people with disabilities are sexual and express their sexuality in ways that as diverse as those without a disability. So just by having a disability does not mean that individual is any less likely to be sexually active or identify in any particular sexual orientation compared to their peers. The belief that people with disabilities are not sexual could stem from the idea that they are considered a child or childlike, as some may have behaviors or patterns that feel childlike, and therefore are often excluded from having sexual health rights. However, most people, including young people, are sexual beings. Therefore, accurate and developmentally appropriate sexual health education, which affirms individuals' own sexuality, is necessary for all of our patients, regardless of whether they have a disability or not. Young people with disabilities may need reassurance that they can have satisfying sexual relationships. So practical guidance on how to do so could be part of that conversation. And I think that's really important. Depending on the disability or physical limitation, these youth may not understand how their sexuality may be applied in the future, right? And so there may need to be discussions about that and how that may occur. The humanity and independence of people with disabilities should certainly be respected in all aspects of care. The idea that people with disabilities are childlike and dependent coincides with the belief that disabled person is somehow unable to participate equally in intimate relationships. There's a lot of societal discomfort, as you all know, both with sexuality and also with sexuality of people who live with disabilities. And that may mean that it is easier to view anyone who lives with a disability as an eternal child, not a developing adult or sexual being. So this is a demeaning view and, of course, ignores their needs and should be avoided in the way we practice all of our care, including our sexual and reproductive health education. So education and skill practice are key to promoting healthy and mutually respectful behaviors regardless of someone's ability. Often when a person with a disability does express their sexuality, they are considered hypersexual, or some feel they may have uncontrollable urges. They are not disproportionately oversexual compared to non-disabled persons. And this is important because it is not expected. The belief in this myth can result in a reluctance to provide sex education for these youth, or a reluctance to even talk about sexuality if a provider is concerned that it may promote a certain behavior. In fact, there's absolutely no data to support either of those two things. Young people with disabilities might struggle with the concept of public versus private and engage in behavior that has been identified as private, or what most of us would think of as more private behavior, such as personal exploration in a public setting. These events could add to the belief that people with disabilities have uncontrollable urges, when in reality, they just need education and skills. So people with disabilities have the right to make decisions about becoming parents as well. Having a child is considered by many an important event in one's life and a right, yet many do not believe it applies to those with disabilities. In many instances, people with disabilities are not believed to be sexual, so it's also believed they would not or cannot reproduce. Or if they can reproduce, that they will have children who also have disabilities. This is not true. There are individuals who believe people with disabilities should not be parents, as they may not be able to adequately provide for their children and so forth. We know that both able and disabled women have an equal chance of having an able or disabled child, statistically equal chance. Women with disabilities, first and foremost, are women, and they have the same rights and abilities to make decisions about their reproductive health and their decision to have a child. The same goes for men as well. People with disabilities can be great parents. They can be just as good as a parent as an able-bodied person, and having the ability to be successful in raising a children, given the appropriate supports they may need based on their disability. And next, learning about sexual health is a necessity, not a luxury, for all of us. So many times, needs are placed into two categories: fundamental, such as eating, sleeping, and bathing, and secondary, sexual needs, desires, communication, intellectual development. While people can value sex differently, for those who do have a disability, learning about one's sexuality and sexual health could be considered by some to be a luxury that cannot be afforded. This could be related to people with disabilities being considered childlike or needing caretaking. Most people experience various needs at the same time and need to learn how to balance all aspects of their lives, including those fundamental and secondary needs. So in terms of sexual health and education, young people need to be present during sexual health lessons at school, learn and practice skills that will support a healthy sexual development. Students with disabilities should not be removed from sexual health lessons for other therapy or pull-out services. And in the home setting, it's important to plan out time to allow for these conversations between parents, caregivers, and their child or youth. Remember that regardless of the disability they live with, young people have feelings, sexual desires, and the need for intimacy and closeness. In order to behave in a sexually responsible manner, they simply need skills, knowledge, and support that, frankly, all adolescents need. Understanding that young people with disabilities are far more vulnerable to sexual abuse than their peers is an important consideration. Sexual health education needs to encompass knowledge and skills that describe and promote healthy relationships and reduce the risk of sexual abuse, as well as encouragement to report and seek help when faced with unwanted sexual advances. Young people with disabilities feel the same discomfort and suffer the same lack of information that hampers many of their peers regarding sex and sexual development. So in terms of background, learn as much as you can about young persons and those with whom you work, including families, cultural traditions, specific disabilities. Be sure that the material addresses boundaries and limits, both setting boundaries and respecting other people's boundaries. And some people use role-playing and interactive exercises when feasible. In a clinical setting, that's usually not practical, but in some school education, that has been used, as well as some community-based education. I think using concrete examples is very important. Abstract concepts such as love, or that a pregnancy results in having a baby 9 months later, can be difficult for people with disabilities to comprehend. Frankly, this can be difficult for all adolescents to understand. The examples used need to be concrete in the present and tangible when possible. Pictures and videos are a great method. And some people are creative on this front, so develop specialized teaching tools and resources for young people with whom you work if you have a sizable population of adolescents with special healthcare needs. So, for example, in working with those who have developmental disabilities, you may need to use visual models, pictures, and so forth. For youth with disabilities, it may be useful to use stories or examples of others with similar disabilities who have loving, satisfying, intimate relationships. So let's talk briefly about tips for healthcare providers. And this is really just overall tips addressing sexuality with parents. And this is parents of any youth. So ask parents, what are their immediate concerns? Are there specific topics that arise when they were speaking with their children that they're concerned about? Are there issues that's harder for them to discuss? Remember to listen and show empathy and encourage open conversation regarding sex with parents. You can certainly educate parents on contraception and emergency options and the importance of confidentiality. Emphasize the importance of parents' awareness of teens' health and address concerns that may arise. Parents often, and I think this is most important, need encouragement during this time. Speaking with them on having age-appropriate books, videos, and so forth could be helpful. Use exploring teachable moments to discuss, observe their children's behavior, and create a safe space for them to feel comfortable talking. And I think acknowledging that this is a really hard time, not just around sexual and reproductive health and development, but adolescence in particular can be a hard time for parents, and many just need encouragement and support through that. When talking with teens, just to recap, we want to make sure we have materials that display our beliefs in confidentiality, anonymous testing services, growth, development, sexual health, contraception, and so forth. Some practices opt to have posters or brochures around with these resources so that it's something a teen could take with them if they don't feel as comfortable talking about it. Education to teens, we want to know, ask them about their current knowledge, ask them what they've learned in school, talk about safe sex, reproductive health, school environment, contraception, emergency options, relationship, sexual activity, the list goes on. And of course, even though we talked about the facts that abstinence-only education is not effective at preventing or delaying sexual behaviors, abstinence is an important part of comprehensive education and so should be a part of the toolbox. And then flexibility. Being able to assist youth through addressing areas in your practice can further make them feel comfortable and at ease. So I think particularly for this age group, offering clinic hours either in the evenings or weekends so that our adolescents don't have to miss a half day of school is really important. Do not require office visits for emergency contraception. That should be something that could be done over the phone or triaged by a nurse or office staff. Providing, of course, anonymous or confidential services, including STI testing. And then do not call or send anything to a patient's home without the adolescent's consent to do so. And these days, it's gotten so much easier now that most of our youth have cell phones and they have their own cell phones. It's gotten so much easier to directly connect with adolescent patients without fear of the parent picking up the phone and having to explain why you need to speak to the adolescent directly. So I think that's made some of these things much easier. There are also ways to assist both parents and teens together. So in waiting rooms, some places opt to have separate waiting rooms for teens or youth. I know that's very impractical for most practices, but some have even just a corner of the room with more age-appropriate materials sitting there, posters and so forth. So the waiting room doesn't just feel like Sesame Street or Disneyland, which I think is important for teens' comfort level. Targeting all ages provides knowledge geared toward all levels of sexual development. So education, we want to just continue to expand sexual health concerns, comfortable spaces, sexual preferences, and so forth. And then, of course, honesty is important for all practice, and being open and honest with patients, increasing trust over time, addressing common concerns and building a relationship. And over time, this will often create an environment where adolescents are more willing and open about what they're thinking about, experiencing, or behaviors they're participating in. I think it's also important in this topic to be honest about what you are comfortable or not comfortable with. And for example, I had a colleague who really struggled with some of the changes in pronouns for patients. And, what worked best for him is to just acknowledge that and say, and show it in a very respectful and caring way that you recognize that person you perceive as a female actually wants to be called he or him, and acknowledging that this is new to you, and apologize. Say, I might make a mistake. I might use the wrong pronoun. That's not because I don't intend to respect your desires to transition and so forth. And I just think it's really helpful for adolescents and teens to hear that. And most are very open and comfortable with, if we're just honest about what we're comfortable with and what we're still learning as providers. So a brief summary. Comprehensive sex education, I hope, is the best method for sexual education, and hopefully that came through. Listening to patients and addressing myths provides reassurance and confidence. Effective programs that are multi-pronged, that include schools, community, and traditional medical settings and office practices are needed. And there's a lot of resources available to support you and the families you work with. So here are just some topics to consider, just a quick overview of some of the things we talked about. So addressing sexuality overall, routinely addressing sexual health issues can help destigmatize the subject of sex and sexual behavior and increases patients' comfort in seeking care and likelihood of making healthy decisions. So with that, and I know we're getting close to the top of the hour, I'm going to transition back to Olivia.
Hi, so thank you again, Dr. Caskey. I just would like to point out that we did actually create a resource guide, so the link is here, and also it is going to be posted on the site. I'll just give you a quick overview. It's the Adolescent Health Provider Education Resources Guide. It has information from the AAP regarding policies. It also goes into some other organizations. It goes into ICAP, what we can offer, and then as well as other organizations like the AMA and the American College of Obstetricians and Gynecologists. And so what you'll find on here is, again, just a wide array of resources that you can use on this topic, and feel free to share. So this will be posted, and it is also in the handout section, so you can download it there as well as with the slide deck. And so just to go back to the presentation really quick, did anyone have any questions? We have a couple minutes, so you can type them in the chat box. I know this topic it can be a little bit tricky. However, hopefully this presentation really helped with feeling comfortable talking about these topics, or even giving you resources in terms of this topic. So please feel free to type into the chat box. And just moving forward, here are the references. They are in the slide deck. And also, as a reminder, live attendees for this for this presentation, you will be emailed a link to complete the online evaluation. Once the evaluation is complete, we will be sending you a CME or CE certificate, and this will happen the week of April 1st. And then also the webinars will be available online in May 2019. We'll be putting them on our learning management system. Okay, so I don't think there are any questions. Dr. Caskey, is there anything else that you'd like to mention for this presentation?
No, thank you, though.
Okay. Thank you so much, everyone, for joining us. Again, this will be posted shortly on our website. And if you have any questions, feel free to email me at ophillips@illinoisaap.com. Thanks. Have a great day.